It's a female with 80 years old. She's no frail, independent. She has a body mass surface of 1.5. She has
So just one point. We just finished a case in another about the same age, 83 years old. She has also the same high, 145, but the weight was 85 kilograms, and here is 57 kilograms.
about
It's a
30.
huge difference.
Yes, 30
Yeah.
kilograms difference.
Yes, that's important. Just to so this is a real small lady, and the BSA 154, and over there was almost 2.
Yes.
Wow.
1.9.
1.9.
Yes.
It's very very interesting.
Yeah, she has a past medical history from hypertension, dyslipidemia, and diabetes. She clinical presentation was dyspnea with class 2, NIHA. She has a Euro score of 1.46 and STs from 3.3. She has a REST EKG with normal, a little bit of left ventricular hypertrophy. Her echo transfer, she has preserved function with a fraction ejection of 60. She has mild mitral regurgitation and mitral stenosis.
So mitral regurgitation, mitral stenosis, the same thing that we saw over there.
45, and he has a error 0.8.
Okay, the gradient, the mean
Yes.
gradient is 45 millimeters.
Yes.
And also the area is
Yes,
0.8.
She has
It's about the same that we saw over there.
severe
Aortic stenosis.
Yes.
Okay.
She has a little bit of a, how can I say, mild to moderate regurgitation in already.
Okay. Can you
Thank you.
make comments about the CT?
Thank you, Louis.
Roberto?
We have an annulus from 25 to 28. It's elliptic annulus with a perimeter of 75 and an area of 342. The valsalva diameters are quite small. They have 27, 28, and 30. It is a tricuspid valve calcified with a calcium score of 100, 196.
Okay, great.
So we have the sinotubular junction of 26 and 30, and the ascending aorta of 32 and 34. So this case has particular extremely small left coronary takeoff of 5.8, and the right coronary is 16.2. So if we go deeper in this evaluation, we have the left coronary smaller than the cuspid height. If we have this kind of behavior of the cuspid height, besides of the coronary height, we have to see the calcium volume in the leaflet. If it's bigger than 600, the risk of coronary obstruction is extremely high. In this kind we don't have, but we have the valve to coronary distance smaller than 3.8. The femoral access, we have no tortuosity, we have good calibers, and we have no calcifications. At this time, as we have the pigtail in the interior in the left ventricle, we are proceeding to place the stiff wire in there.
Okay, good.
Okay.
Great, thank you. Now he's bringing the wire inside of the left ventricle. As I mentioned before, it's a very important part of the procedure to avoid any kind of perforation or something like this, to have a good position of the stiff wire in the LV. What size of the balloon you choose, Louis?
The 20, it's a 20,
20?
yes, 20 balloon.
Pedro, can you start at 100?
It's 20 by?
20 by what, Louis? The
20
balloon?
by 20.
20 by 20, okay.
100, please.
Pacemaker?
Yeah, I think it's okay. Can turn off, please? Pacemaker off. I'll cross the annulus.
Now position the balloon. So are you doing a minimalist approach, or you choose general anesthesia for this case?
We choose general anesthesia because of this particular scenario of extremely low coronary takeoff.
Okay, good to know.
Okay. Pedro, can you start the pacemaker, please?
Perhaps we see the hemodynamics too, Fausto. If you see the hemodynamics too, because we are going to do
Okay, may you have the
100.
hemodynamics in the screen, please?
180. Injeta.
The hemodynamics in the left. Okay, great. Thank you.
Pacemaker off.
Okay,
Good.
great. It's great. The blood pressure is okay. Can you have only the guide wire
pegar
over there, Dimitri? Or should we
That's a good
do
question.
a full protection?
Yeah, sometimes it's difficult to push the stent if you have a coronary occlusion. So it's sometimes it's better to place the stent on the LAD, and then if needed, we can retract the stent and
Okay.
enter the left main.
I understand what you mean. So you were saying this, I would vote to do a protection with the stent inside of the coronary artery with the mother and child catheter and everything.
So the patient became a little bit on tachycardia, but now it's becoming more stable now.
Is
And
more stable?
yeah, now it's more stable. Yeah, it was tachycardia before.
Yeah.
Yeah.
Okay.
So Dimitri is placing the guide wire distal to the LAD. There is no disease. It's almost a normal coronary artery.
Yes, normal coronary. Yes. And now, I think I'm gonna use it
There's some virtuosity down there. I think a good
Have
position.
you opened the mother and child, the guide?
No, I'm going to open it.
Okay.
And the modern
Great.
child allows
Good-
you not
good
to have to
position.
put a stent already.
You
You
need
just
a test there just to check? No.
Yeah, let's go.
you just have a catheter to deliver if you need it.
Okay,
It is good.
perfect, perfect. And Dimitri is going to tell us what he's going to do later. It's if he's going to have like a mother and child and why he's going to use this. Just to have the stent inside of this protector catheter.
Okay.
Now he's advanced the coronary stent, is distal,
We're gonna leave
in
the
mid
stent
portion
here,
of LAD, as you can see here.
and then we are ready to implant the valve.
Okay.
At Dante, in the cath lab. Now Dimitri is advanced. Can you have the hands here with Louis, Alberto, and Dimitri, please, instead of the hemodynamics?
I think we have to place again the pigtail.
Okay.
And he advanced the valve, the accurate knee, very easily through the aorta. And now it's getting close to the valve.
So here
Now
we can see the 3 posts, right?
Yeah.
And free stent edge at the cusp overlap view.
The first
So
was the
you want to see the
accused
3 markers,
overlap.
not the overlap of the 2 and 1.
So here we
If you
can
have
see
that,
the
you have to.
posts, right?
Yeah.
Yeah.
And the free stent edge.
So what is the view, the degrees of the?
This
Yeah.
is RAO 8 and caudal 18. The other position is
Yeah, I can.
left
Yeah,
15,
it's safe here.
right?
Here.
So Dimitri, when you're doing this, you can just leave the catheter, guiding catheter in the left main
No, we're gonna retract the catheter
before you deliver.
Yeah.
Okay.
I'm gonna rotate a little bit just to see the
So you're rotating here counterclockwise.
just to see the
You can do the narrative, please.
You want to see the 3 markers, right?
yeah the 3 posts and
The 3 posts, yes.
the 2 stent free edges here.
Okay.
So let's start the deployment. 3 cuspes.
So now we're going to start deployment.
Pode ser, tem que ser à esquerda.
So the guiding catheter should be there, or
Yeah, I'm gonna retract that.
So now Dimitri is advancing.
you work there, and we're
Quem tá
going
na
to be
bomba?
concentrating talking here,
Yeah.
okay? You and
Tá na
Alberto
bomba.
just doing the case, and Ricardo and I, myself, we're going to.
So he's retrieving here
Okay.
the guiding catheter in the left main because you don't want to have the catheter there in
Okay.
between the valve and the aortic wall.
It's a good.
But he kept
Now he
wire there
advanced the valve.
and the stent in the same position. He advanced the valve, he crossed the valve. Now he's going with the pigtail to be
Tell about the marker,
non-cuspid.
Ricardo, please.
Yeah, so we have the mid marker that needs to be exactly at the low curvature of the pigtail,
And that means
which is the
it's
annulus.
in
You are just at the
mid portion,
annulus.
in the middle of the aorta.
Yes,
the valve.
just at the annulus, yes.
The annulus.
So
Okay.
now everything needs to be checked, you see, just at the lower curvature there. I think it's a very good position.
Yeah.
Ricardo,
So
please.
he's opening here the first crown.
Uh-huh.
Device has the advantage of preserve the hemodynamics as it is released. So he's continue, and it's always you checking with angel, always checking with angel, which makes also make sure you are in the right
mark is
position.
exactly the same
The same
point.
position, yes. So you see
the
the
annulus.
opening of the upper crown,
Uh-huh.
and that captures the leaflet as well.
And Alberto
So
is
it's
making a clock
annular position.
clockwise.
Counterclockwise.
He's doing anti-clockwise,
first
counterclock. So the first crown, I think it's there, right, Alberto?
Yeah.
We just finished. So now he's removing. We can see in his hands, and the control. You see the control angel here. So Dimitri, do you need to do any position here? Fine, refine it.
I think so.
Pull a little bit, right?
Let's remove the button.
So at this point, Fausto, you can still pull a little bit, push forward a little bit,
Yes,
just
you can
find adjustment.
reposition there.
Yes. And now he just opened the second.
Okay.
And the second crown needs to be very fast. It looks like it was well preserved.
We try to put the valve a little bit lower
Yeah.
Yes.
just to prevent coronary
Yeah.
Yes,
occlusion.
we could see that. It's
could
about
see that,
three
yeah.
quarters inside of the
Yeah.
LV and 1/4 in the
Yeah.
aorta.
Yeah. This is a technique you can adjust because of the anatomic situation here.
Okay, great.
So,
So you
preserved.
can see
Yeah.
the valve there. And
And you can see the leaflet just in the side of the takeoff, the left main holding the die there. So
So
now,
now, Fausto,
this is the effect that you have.
Yeah,
the,
yes,
the,
we saw
the
again,
crushing.
a low takeoff from the from left coronary. And still, we didn't get any occlusion. So it's how can I say? It's we have to admire the device.
technique.
Yes, the technique of the device, because there's no how can I say? There's no incidence from coronary
So,
occlusion
Andrea,
with the accurate.
so
Any
would you
findings
implant
here?
a balloon expander in this case?
Perhaps if I would try it not. I would,
No, no.
If you can show, okay, Andrea, so can you mention? You saw a good positioning, right? So no paravalvular leak. Okay, so they can confirm that the good flow in the coronary artery, especially the left main. And what about, do you see any gradient, anything more important that?
Great. Great work.
So no pericardial effusion, right? So everything it's very stable, which is good. So since the patient is under general anesthesia, we're doing TEE as well, and of course they can offer some nice images and.
That was a nice demonstration because after the deployment, they injected in the aorta and you could see the coronary artery
Yeah,
quite open.
yeah, and Dimitri used the technique to lead a little bit deeper just to preserve that.
We got a low
Yeah.
position
Yeah.
in the annulus.
So there is some, as we see in medicine, everything has an advantage and a disadvantage.
yes.
Disadvantage.
Yeah,
So what
and you have to work between the margins.
What reminds us to that very famous sentence: every problem has a solution, and every solution has a problem. If you compare to the other room, you had like a medium gradient was 11, and now it's 6.
Yeah.
And there is no regurgitation, no paravalvular leak, no pericardial effusion. The patient is just fine.
And just as we discussed in the previous case, this processes has this feature that keeps
Yeah,
accommodating,
yeah.
and it can improve the hemodynamics over time.
And the heart rhythm is great. And
It's very stable, very stable.
reproducing our experience with this device here in the past 10 years. There is no coronary occlusion with this, fortunately, as Dimitri has mentioned before. In all cases, there was no paravascular, and the incidence of pacemaker is quite low. Did you take a look in that?
I didn't take a look, but I caught my attention.
Yeah, Dimitri said it's less than 7%.
Dimitri mentioned about 6%.
6%. Okay. So Dimitri, what are you going to do now?
So let's do some measurement here about the hemodynamic.
Okay. So the hemodynamic is measured now.
It's no gradient there.
Say
It's like 5, 3, 4.
5, 3, yeah.
3, 4
And with a good
gradient. 3,
diastolic.
4 millimeters.
The valve seems a little bit unexpended at the annulus because it was definitely a too low position because of the low coronary ostia. But the hemodynamics are good and no paravalvular leak.
Okay. Coronary artery looks good.
So
Yeah.
There's some spasm or not?
I think because of the stent.
The stent.
here.
Maybe you can bring the stent out now and take a
Let's
look
do it.
without this.
yeah.
It's important to keep the catheter
engaged.
But
inside.
also is
Yeah,
it
inside.
the
So
left
now, what
coronary.
Dimitri is saying is very important now. He kept the guiding catheter inside to avoid any stent that can go to the strut valve. Is that correct? What I said? Okay.
And also, it's interesting to see this angel, even though the left main is open at takeoff, it's free, but it's very close to the valve strut.
Yes.
If he was a little bit upper, we'll have some kind of compromise.
Yes.
So
That
this
was
has to
a
be the
very
accurate
important
technique. No,
That's just perfect.
I like this very much.
No
This is
regurgitation.
as it need to be, you know,
Yeah.
Let's see the coronary artery.
to preserve the left main.
So, if you were like 1 or 2 millimeter higher, do you think we can have some problem with in the left coronary?
Yeah, that's a tough question. But the fact that also is that the QRS are not wide, so we don't got any conduction disturbance so far. Even implanted this valve lower than we did in our practice.
Because if you're a bit lower, you're more likely to have some conduction disturbance, right? Yeah. Demonstrate. It looks like an easy case. It's not an easy case. This is very, very complex, difficult case. But it appears to be very easy. And this is because we have routine now. We have protocols that we follow very strictly. We have very advanced technique.
Yeah. I think we did an excellent job, Dimitri. Congratulations to you and
to everybody.
Alberto Cervoni, Louis, and also Jose, who is working with us, and Ricardo. Thank you. I'll see you next Wednesday.
Thank you.
Thank you.
Thank you.